Thank you very much to IDCM organizers. So I personally thank Dr. Parag Rana, Dr. Kamaldeep and Akash Singh for giving me this opportunity. Again, second in just one session. That is really too good. Actually, my lecture should have been before Manokar's lecture, because when we fail, when we can't do everything, comes the heart transplant. But heart transplant lecture preceded me. I don't know how the order is reversed. And I think since morning we are discussing about inadequate control of cholesterol, glycosylated hemoglobin A, and probably heart failure as well. So in spite of best possible available guideline directed medical treatment, only 40 to 50% people probably achieve the target that we are aiming at. So we are always looking for something new which is still not available. And I think with this successful conference, I would call this conference Metacon conference and Megacon conference. It's a really mega success, and within 3 years you have achieved really good milestones, and each time you see new topics and new speakers, and really I appreciate it. So my topic is worsening heart failure. What is different? Means everyone knows what are the 4 pillars of heart treatment, how they work, what are the doses and everything. So is there anything different? That is what I am going to discuss. So basically, whenever patient heart failure, our aim is to alleviate the symptoms, slow the progression of disease and improve the survival, and if they have end stage heart failure, to refer to Manoker. So these are the basic standard treatment which concludes symptom control, the comorbidity disease control like hypertension, diabetes, AF. As he very rightly said, if you control fast heart rate in patient with AF, half of the time they recover quite significantly. We now know the role of correction of anemia not by oral treatment, by intravenous IV iron, also risk factor reductions, and these are the basic mainstay of treatment that all of you know. There is no need to talk and discuss. But though there are 4 main pillars, there are many additional important medicines. As for example, patient with coronary disease, they have to be on statin and aspirin, and there are few mechanical treatment which includes bypass surgery, CRT device, temporarily left ventricular assistance device, etc., etc. These are all different type of treatments that is available at the moment, of which ACE inhibitors, ARBs, ARNI, they reduces the mortality. Same is for beta blockers, mineralocorticoids, and even isoleucine, which is not very commonly used. I don't know why we don't use that often, but especially those with very high blood pressure or where there is a contraindication to first 3 because of renal disease, isoleucine is one of the most important. One study shows it is most effective, but I don't know why we are not using it that often. SGLT2 is a new blocker, and many people say this diabetic maybe has come from diabetologist to cardiologist domain, because we are now using it more often than diabetes probably. Digoxin has gone out of phase, but still I would consider its use if patients AF with very fast ventricular rate. And in old days it was one of the most common medicines. Still it reduces the heart failure admission, but it doesn't change the mortality, but it reduces symptoms significantly in AF. Loop diuretics are number 1 in acute stage, though they do not do mortality changes, but in acute failure, nothing works better than loop diuretics. And today I am going to talk more about a newer medicine which is more to reduce heart failure hospitalizations. So this has been already mentioned. Once heart failure, it's a very progressive disease. There is no need to go into detail about it. So unfortunately, though we have 4 important medicines, they have a lot of limitation. As for example, ACE inhibitors, ARBs and ARNI has made so much difference that few of my patients with LBB who were on list for CRTD, improvement was so much that we had to avoid putting CRTD. Maybe that is true for few of the heart transplant recipient waiting list patient also. But unfortunately, side effects are so much that 20 to 30% patient cannot tolerate ACE inhibitors, ARBs or ARNI, and that is very big issues. Beta blockers also, all of you know some contraindications. Same is true for SGLT2, to 10 to 20% they get severe UTI and we cannot use it. While all other therapy is not suitable for every patient. As for example, CRTD only in those with heart failure with LBBB. And not all patients with LBB also respond well to CRTD. So in general, these are the costly therapy and they are very limited applications. So what do you do in those patients who have repeated heart failure? So in spite of guideline directed medical therapy, in spite of doing all the things that we can do, many of the patients, they still come back with repeated heart failure hospitalizations, and once they are hospitalized, their prognosis get worsened. As for example, you can say 1 in 5%, 20% patient die within first year because of worsening heart failure, because within 2 years. So this is just example of one lady who had a heart failure in 2022, and in spite of being on maximum treatment, she has class 3 angina on repeated occasions. EF is only 20%, and recently she has chest pain, hemoptysis and other symptoms. Now, diagnosis was dilated cardiomyopathy. She had low iron level and she was given that. This is the first time that she came on admission, and this is the echo showing very severe LV dysfunction. These are a few of the criteria. She is already on maximum medical treatment before the first heart failure presentation because of LV dysfunction. Now, what should we do in this situation? That we'll discuss little later. So, question to address in such situation, when patient comes for OPD or for the first time in heart failure and then discharge, how do you identify who are the patients who are going to get repeated heart failures? What should you do to reduce repeated heart failure in those with reduced ejection fraction? I am not talking about heart failure patient with preserved ejection fraction, but those with reduced ejection fractions. So, 4 important points to be considered in this is, how do you identify patient with worsening heart? See, once patient comes with frank heart failure, everyone can diagnose. We have to identify those who are still not in heart failure or who are going to develop that. I think in previous lecture we very rightly said artificial intelligence can do it. But let me tell you, even common sense and education to patient can help identify people who are going to get heart failure. So before they get prompt heart failure, if you ask patient to daily weight, identify them how to identify the edema, initial symptoms, probably we can identify some of the patient before they actually need hospitalization. So that is one of the things that we have to understand. We should know what are the baselines therapy and how patients should be educated to increase or decrease diuretics, because if you increase oral diuretics, you can reduce acute heart failure admission in many of the cases. Those patients who require escalation of therapy, it means if you have a patient with severe heart failure, even if the symptoms are well controlled, you must try to optimize and increase the dose of ARNI to the maximum tolerable depending upon his blood pressure, dizziness symptoms and creatinine function. So if you do that, probably you can avoid many of these patients. So whom you consider heart failure or worsening heart failure, means these are the definition of worsening heart failure. Those who are already proved heart failure patient with reduced ejection fractions, in spite of maximum medical therapy, they require more intensification in the form of diuretics. Probably we can call them as a patient with a worsening heart failure. And they require usually escalation of treatment or at least oral or even on OPD basis IV diuretics. And these are all considered very high risk patients if they require repeated heart failure hospitalizations. I am not going to detail about certain things. So basically, even if patients are on maximum possible medical therapy, as for example, this is 3 well-known therapy, ARNI, beta blocker, MRA, 20% patients still get repeated heart failure admissions. If you add dapagliflozin or empagliflozin, you can reduce heart failure hospitalization by about another 5%, but in spite of that 14%, that means 1 in 7 person, they still require repeated heart failure hospitalization. How do you reduce this heart failure hospitalization? That is what our aim is. And this is the standard therapy we have, all of know how they work. We are talking about the 5th pillar. I don't know, it is still not added, but it may be added because this is the only therapy which works by positive mechanism. As for example, beta blocker acts by negative mechanism by suppressing sympathetic activities. Well, verisuguate is the one which stimulates energy generation GMP into the cellular level, and that is how it works. I am not going to detail about it, but it has independent and synergetic effect which stimulates basically soluble glycinate cyclase, and that stimulation increases cyclic GMP, which is one of the energy source for the myocardial muscle. So this is for the first time different way of mechanism to improve the cardiac functions. This is how it works. So ultimately, with nitric oxide dependent and inefficient ways, it increases GTP conversion to cyclic GMP, and these are the end stage or beneficial effect, ultimately result into decreased heart failure and decreased hospitalization. It has a lot of long-term implication also, and maybe this will result into decreased mortality over long-term basis. So in majority trials, when patient has severe heart failure, we start some medicines. This trial was at the moment for those who are in that category, that is worsening the heart failure. Maybe in future application and indication may increase, and you may use this new molecule in a patient who still doesn't have a heart failure or need for the heart failure admission. So it's like when we started using TAVR, it was initially in only very high risk patient. Now TAVR or percutaneous aortic valve replacement has become so successful that in Europe, America, in 65 plus, 90% patients are subjected to TAVR. Only 10% by open heart surgery. So probably whenever new therapy comes, initially it is projected to very high risk patient, and once it shows its success, it may have applied or additional indications. That is what happens. One of the biggest trial was Victoria trial, in which this very high risk patient with worsening heart failure, repeated heart failure hospitals were included, and compared to all other heart failure trials, you can see they were the patient who were more high risk patient with much higher median anti-pro-BNP levels, with more sicker patient. So they were really genuinely serious patients and with a worsening heart failure. And it shows about, of course, when you see statistics, it doesn't look that impressive, but even if you reduce 3 or 33 events per 100 patient in a year, it's a very big relatively risk reduction. That is what we have achieved with this trial, and that is what it shows. Tolerability was reasonably good. That's good part about all these new medicines. It doesn't show any major worsening of GFR or creatinine worsening of potassium elevations. Blood pressure didn't go down as much as with any of the medicines. It's only SGLT2 and verisuguet which do not reduce the blood pressure, and that is why they are tolerated. See, one of the worst problem of ARNI, which is the best medicine in heart failure, is that 20% patient can't tolerate it because of low blood pressure. Sicker the patient, lower the blood pressure. That is a big issue actually. And similar is case for the beta blockers and diuretics. So those who actually need more medicine, they cannot tolerate it because of low blood pressure. That's a problem that we have seen. While here, this medicine is tolerated by majority of the patients. And unlike all the medicine, like as for example, if you say ARNI, how many of your patients are 200 milligram BD? Very few. You start with 50 milligram. In India, we start with 50 milligram half, which is not recommended dose. But very few patients can be escalated to higher dose. But as far as this medicine is concerned, we started with 2.5 milligram and increased on 2 weekly interval to 10 milligram. Majority of the patient can tolerate and go up to 10 milligram, which tolerance level is so high. That is the biggest advantage. Of course, one of the thing is it works in first 3 quarters of the patient with severe increase in BNP. Those with very high BNP, like more than 5,000, probably this medicine doesn't work. So we have to actually act much earlier before it is too late. That is what we have to see. And in spite of this, compared to other medicine, it shows much more improvement in heart failure related admissions. So in this patient, as for example, one which we have already said, she was already on reasonably good medicine. What we can do is we can increase the dose of sacubitril valsartan to the maximum tolerable, but the question is not all patients can tolerate that dose. For dapagliflozin, usually 10 is maximum dose that we can see. What we can do and add is increase verisuguet, starting with 2.5 milligram, make it 10 milligram. Now in this patient, if you see what was the number of admissions in a hospital of 6 months, and after putting on this, they reduce it quite significantly. I have many patients and we have seen clinically the dose requirement or rather admission hospitalization has gone down. Only thing is those who have very severe heart failure, they don't do as much benefit. So algorithm is all type of heart failure patients can be put into this medicine in different clinical scenarios. As for example, those who are already on maximum treatment, very severe heart failure, repeated hospital admission, you can put them on. Very few patients they have side effects or contraindications, and that's the best part of it. So in all this clinical scenario, you can start these new medications. Patient who experience decompensated heart failure in spite of maximum therapy. Number 2, contraindication of the maximum possible therapy or intolerance to the therapy. Or number 3, we can start probably early at the time of first heart failure hospitalization to prevent further hospitalization. Only thing you have to be careful is you should start more than 24 hours after IV diuretics have been stopped. That is the biggest thing that we should. So these are the 3 indications or scenarios where we can start verisuguet. The best time is to start is either before patient is discharged or on first or second follow-up visit. And another thing, of course, this is not related only to this medicine, is we have 4 pillars. And many people, they start with 1 pillar first and they increase the dose on optimized. But one of the studies shows it's better to start all 4 in a lower dose and then optimize them individually over period of follow-up. So instead of putting on one medicine, you better start all 4 pillars as per the tolerance and indication, contraindication, and then optimize the dose. That's the best thing that we should do. And as I mentioned, in few cases, probably we can start with verisuguet as well. So this is probably a 5th pillar, quintuple pillar. That is what is going to be the future. At the moment, it is not done, but that would happen. And this is how you escalate dose or 2 weekly intervals. 90% patient, you can reach to the 10 milligram dose, and that's probably we can do it. So how do you start it? Start it 24 hours after the IV diuretics are stopped. those who have more than 15 eGFR, best thing is to start it as early as possible, that means in the hospital before the discharge, because patients already has a heart failure. We don't want them to come back with repeated heart failures. But sometimes if you fail on that time, second or third visit, ideally first visit on follow-up, you can start it. That is what we can do it. And it can be started simultaneously with any of the 4 pillars that we already mentioned. Majority therapy is to treat the patient, while varicogate is more for prevention of heart failure admission. It doesn't reduce your heart failure symptoms. So it doesn't work if patient has heart failure symptoms, it's more for prevention. So the key point is, we have already standard 4 therapy, this is going to be 5th therapy. Start it as early as possible, preferably before the discharge. There are very few contraindications, very well tolerated with other medicines and very well tolerated. That is what we can say in this situation. So this is how our heart failure summary can be like this. The first and the most simple is ARMY, then comes beta blocker, mineralocorticoid, not the diuretics except in acute situation, SGLT2, and then comes varicogate. These are the whole thing that we can consider. You have to treat comorbidities like atrial fibrillations, if there is wide QRS and LVB CRT device, very fast acted ivabradine in spite of maximum dose of beta blockers. So this is what we can summarize it. Surgery and mechanical repair also always have its own role. Mitral clip is now coming in way. Those with very severe heart LV dysfunction and severe secondary MR, surgery is out of question, is very high risk. We can do mitral clip to reduce the mitral regurgitation. So basically I can just summarize, varicogate is very effective in reducing cardiac insufficiency, acting primarily on GMP pathway. At the moment it is underutilized, but I want that it should be used, very important and a very useful addition to the treatment of heart failure. And can anyone know what is the brand name of varicogate? Brand name, anyone can say? Yes, so it was very difficult for me to remember, so I remembered like this. What do you see here? Vergu, yes, this is just joke. So I think I will end here.